Can you hear me okay? I do have you on my office speakerphone.
Yes,
Yes.
I hear you really
Okay,
good.
before anyone else joins.
Good morning. We will start right at 12. Thank you so much for being early birds and jumping on for our call or webinar. I'm sorry. Good afternoon, everyone. Thank you for joining our webinar. My name is Michael Whitfield, and I work with Healthy Mothers, Healthy Babies Coalition in Georgia. This webinar was presented in collaboration with Healthy Mothers, Healthy Babies and the Georgia Perinatal Association. So I just want to thank them for their partnership on this. And if you don't know Healthy Mothers, Healthy Babies, we seek to improve maternal and infant health through education, advocacy, and access to vital resources. We also offer a number of webinars. So if you are not already a part of our webinar list, you will be added after today. But if you want to see any upcoming events, feel free to visit any of the links you see on the screen. So there will be CE credits available for this 1-hour webinar for nursing, one nursing contact hour. And following the webinar, you will receive an evaluation. And once you've completed that evaluation, we'll send you your certificate within a week. So just FYI, and I'll mention that again at the end, as well as any questions you have for our presenters. If you'll just put them in the questions box, we will have some time for questions at the end. I may not be able to unmute everyone for your questions, but if you'll put them in the questions box, I'll be sure to get them by the end. Okay, so our presenters this afternoon are Marcie Finney, and she's the Executive Director of the Cleveland Cord Blood Center. She has an extensive background in the field of cord blood. She spent over 10 years at Case Western Reserve University, where she participated in cord blood research. As the Executive Director, her responsibilities include strategic planning, finance, administration, and quality product development. She's active in the cellular therapy industry, and prior to her current role, she served as the organization's Director of Hospital Relations, where she had education and training of collection coordinators and medical staff at hospital collection sites. She has a Master's of Science in Chemistry, as well as a Bachelor of Science in Chemistry. Our next presenter is Candice Laster. She is the Atlanta Hospital Liaison for the Cleveland Cord Blood Center. She began her nursing career in 2007 at the Cleveland Clinic as a medical surgical telemetry nurse. In 2008, she transferred to labor and delivery within that same hospital organization as a cord blood nurse. She was within the first group that will be screening, educating, collecting for Cleveland Cord Blood Center. Throughout the years, she's been able to gain knowledge around public cord banking, its uses, and the importance of meticulously screening and documenting medical history. In 2012, she relocated to Atlanta to become the member of management as the hospital liaison at the Cleveland Cord Blood Center. She has successfully assisted with the startup of the joint ventures between Emory Midtown Hospital and Piedmont Atlanta Hospital. She now trains all of the cord blood coordinators and has built a relationship and educated OBs and midwives that deliver at both these hospitals. So we have some presenters that are well versed on this topic, and I will pass it over to them to begin. Marcie and Candice.
Great, thank you.
Thank you.
Trying to see if I can get it to change the slide. Oh, there we go. So thanks for that great introduction. So today we're going to talk and give you a guide to public cord blood banking for maternal and child health professionals. And as Micah indicated, Candice Laster and I will do different parts of the presentation, and we have both different perspectives on the banking into public cord blood banking field. I work more at the bank side of things, and Candice handles most of the patient interaction and physician and midwife and nurse interactions at our Atlanta sites. So we're hoping that the two of us combined can give you some good perspectives, and we hope to leave lots of time at the end for questions, so make sure you fill out the question box. So let's see. So a couple of the topics that we want to go through today, we're going to talk about cord blood banking and current uses of cord blood. We're going to talk a little bit about patient education, and then a little bit about the Cleveland Cord Blood Center itself to just give you an indication about what a public bank looks like and what we do here. And then Candice will finish up also with talking about Atlanta's public cord blood banking program and the impact that it's had. So some of the background about umbilical cord blood, approximately every 3 minutes, one person in the United States is diagnosed with a blood cancer. So umbilical cord blood can be used to treat those patients. It's often the best or only hope for cure for some patients with leukemia and lymphoma. Patients can also get a bone marrow transplant from an adult. So if you hear that term of a stem cell transplant, they can come from either a bone marrow or an umbilical cord blood. Cord blood is used in 33% of pediatric patients and 11% of adult patients. Cord blood is often an option for patients with uncommon HLA types, and your HLA is your human leukocyte antigen, and we'll talk a little bit more about that later. It's your DNA fingerprint, and it does go along your ethnic and racial background. So cord bloods from the same race or ethnic background that you are most likely to match you. So many African Americans get umbilical cord blood transplants, and I'll show you some data about that in a little bit too. Cord blood is also an option for many patients who have difficulty finding that matched adult marrow donor, and only 30% of patients will have a match among their family members. Cord blood is also an often used option for patients who have an immediate need for transplant. So you think about, for us, the umbilical cord blood is already frozen. We test it and store it frozen, so we can ship it tomorrow if we need to. If a physician is going to use a bone marrow transplant from an adult, they actually have to find the adult, maybe they don't live in the same place, and schedule a physical and schedule the harvesting of the bone marrow. So it can take a little bit more time sometimes than a cord blood. A cord blood, we can ship them as soon as tomorrow because they're already ready to go. So some of the diseases for which cord blood is currently used for, in the malignant disease category, is leukemia and lymphoma and multiple myeloma, and those are mostly the ones that we see physicians using cord bloods from our center to treat. But we are seeing more of the non-malignant disorders, which is thalassemia, hemoglobinopathies, Fanconi's anemia, and immunodeficiency syndromes. We see some of those, but still most of the patients that get treated with cord bloods from our center and cord bloods in general are in that malignant category with leukemia and lymphoma mostly. So I mentioned this earlier, but this slide shows the percentage of transplants that come from different sources. The green, it shows from a bone marrow or peripheral blood from an adult. So you can see in the white population, 90% come from that adult registry, and 10% in this blue slice comes from cord blood. If you look at the African American pie chart, you'll see that 34% comes from umbilical cord blood. So in those minority populations, you can see that there's more transplants that happen with cord blood than there are for the white patient population. So we find that that is part of our mission to make sure that there are cord bloods available for all the ethnic backgrounds. So at the Cleveland Cord Blood Center, I wanted to just show you a snapshot of the different cord blood units that are added to the National Registry from our center. So we really add a lot of multi-race units and a lot of African American units, and we're getting more and more Asian units from our collection sites. So I mentioned earlier a little bit about HLA and matching. So human leukocyte antigen is basically your DNA fingerprint. It's what makes you you. And HLA mismatch is more tolerated in a cord blood, and I'm going to show a picture in a minute that I think explains this better. But umbilical cord blood doesn't have to be totally matched like an adult donor does. There can be some mismatch, and that has led to the use of cord blood in especially minority patients. So the HLA antigens are proteins that are found on the surface of most cells in the body. That's how the cells in your body know that they belong to you. And then the immune system uses those HLA markers to verify that the cell is not foreign. There are many different HLA proteins. In the transplant space, we focus mainly on HLA A, B, C, DR, DB, and DQ. But there are very many varieties of each one of those among populations of people. So when we talk about HLA matching and you hear those terms, probably a genetics professor wouldn't like this version, but it makes sense to me. So you hear the term that about 30% of patients will have an HLA matched sibling. So you're most likely to match your sibling. So if you look at the top, you see the mother has, we just looked at 4 HLAs for simplicity. There's each person, the mother has 2 different HLA A's, B's, C's, and DRs. And the father has 2 different HLA A, B, C, and DR. So their children could have any one of the 4 combinations that you see below. So these children all come from the same parents, but they get one set of A from mother and one set of A from the father, and then they mix together. So there is a 30% chance that you would have a match among your siblings. You could have a 0 match, like in this case. They had 4 children, and all 4 have different HLAs. But if you look at this slide, let's suppose that this child here, all the way to the left, needs a transplant. So this is what their HLA looks like. So they could have one sibling, like the second example, child 2, that has only a 4 of 8 match. They got all the exact same HLAs from mom, but a totally different set from dad. Or you could have a half match again, 4 of 8, in child 3, where they got totally different HLAs from mom, but the exact same ones from dad. Or you could have that, like in the case of child 4, that they have nothing in common. That can happen also. There is not a huge biological preference for one set of HLA. It's from all the reading I've done about it, it's very random what a set of 4 siblings might have as far as matching. So if we look at the example in this slide where this particular patient needs to have a stem cell transplant, and these colored circles represent their HLA for our discussion. In order to use an adult donor or a bone marrow donor, they would have to be an exact match, the way this looks right here in the center. However, with an umbilical cord blood transplant, they need to only match in 4 spots. So you can see the top 2 in A both match, the right 1 in B match, and the very bottom left in DR match. So in order to use a cord blood successfully, they only need to match in 4 spots versus 8, like it is shown in this center example. That makes cord blood a little more versatile and serves a bit of a greater population as we collect them. We talked about some of the classic uses of cord blood and the things that are approved right now, and most of it is leukemia and lymphoma, and all of them are blood disorders. However, if you go and Google umbilical cord blood clinical trials, there will be clinical trials on almost anything you can think of. Some of the recent ones in an allogeneic setting, which means from one person to another. There are inborn error clinical trials going on for neuroblastoma, for multiple sclerosis. So these trials are underway and are new uses for umbilical cord blood. If you look for autologous trials, which means using the child or baby's own cord blood, you see that there are some trials for hypoxic ischemia, for autism, for neural injury and cerebral palsy, and even type 1 diabetes. So there are new emerging uses for cord blood that we're seeing all the time. So I've given you a little bit of cord blood background and some current uses of cord blood. Candice is going to now talk a little bit about patient education.
Thank you, Marcie. So I do a lot of the patient education down here with the OBs and the midwives, and we deal with a lot of residents as well. And then at both of our hospitals that we have down here with Emory and Piedmont, we just try to make sure that they have all the information that they need. And we have cord blood coordinators, so they help when the patients are admitted into the hospital. But the medical providers play a leading role in educating their patients. A lot of patients are very interested to see what their OBGYN or midwife would prefer for them to do. They really do trust them and look toward them. Since there's so much information out there, I think that they like to talk to their OBGYNs or midwives more often than none. They desire more information. So we have cord blood coordinators at both of our sites, and we pretty much staff 24/7. So whether they come in the morning, at night, on the weekends, we have coordinators that are there that can help answer any questions alongside the OBs or just go and educate the patients and help them make a decision. The providers are very well versed in cord blood. I know there is a law down here where they're supposed to educate them in their second trimester. But a lot of patients forget all about that. So that's why it's really good that we have the cord blood coordinators at both facilities, because of pregnancy brain, and people totally forget what they've seen, what they've been informed, what type of information they've gotten throughout their pregnancy. Next slide. So these are the options that all patients are presented with. So our goal is just to ensure that they're educated and they know their options. Our overall goal is just that none of the cord blood is discarded and thrown in the trash. So they have different options. They're able to donate their baby's umbilical cord blood at our 2 facilities in Atlanta, and then we have 2 facilities in Cleveland and another one in California where they are able to publicly donate their baby's cord blood. Everything's free. We never ask for anything from them other than we need to be able to have a consent form signed. We need contact information so that we are able to follow up with these parents once they've gone home with the baby. And is to help them understand that it's not saved specifically for their family. It's listed on the Be the Match registry along with the bone marrow. And we also do let them know that not all of our units are processed, so we do use them for research. And they have the option to allow us to use it for research, or they can opt out of that. And then I know a lot of the patients always think, when they think of cord blood, they think that it's just for children. So the good thing is that when we're there and we educate them, we help them understand that it can go to a child or an adult. So I think that's the biggest part that I'm noticing, that patients think that it's solely for babies. And it's not. So that's a good thing about the public donation. They can do family banking. And as we all know, they get a lot of information throughout their pregnancy. Some of our hospitals down here do keep some of those private kits on site. And we always make sure they know that these are their options, so that they don't think that we're trying to pressure them to go one way or another. But when they bank it privately, we let them know that it is a storage and a processing fee. They do need to have that all set up on their own, just so that they know that that's what they're going to have to focus on, is ensuring that it's picked up and shipped to where it's supposed to be shipped, because we don't necessarily handle it. And then you can also do sibling-directed collections. And so I know one of the private banks offer it, where if you have a sibling and that child has to have the same parent as the baby that's being born, so mom and dad have to be the same. And if that child, say, has sickle cell or leukemia, they will bank it for free for up to 5 years, and then they reevaluate after that. If it's still a need that may need to be met in their family, and they'll continue to bank it for free. So we do make sure that we pay attention as the cord blood coordinators, because sometimes, that gets lost in translation by the time that they come to deliver, and they don't even know that this is an option. So we do try to heavily screen these patients and look through their prenatal records, and usually you'll see if there is a history of something in one of their other children, and we will help them, ensure that their unit is stored in one of those private banks so that they can use it for their other child. And then we also let them know that it can be discarded. Our goal is that none of them go in the trash. But as we all know, we can't make them make a decision with us. But our only hope is that they're educated and they truly understand what their options are and prefer not to throw it in the trash. Next slide. So when we're educating the patients, there's a lot of stuff that's in the news regarding embryonic stem cells. So that's always the number one question. So we do let them know that cord blood stem cells are totally different. They do not come directly from an embryo. They are adult immature cells. So meaning they don't have the ability at this point to attack foreign substances, but they're not embryonic stem cells. And usually patients are happy when you explain it to them that way. They usually get it. We let them know we're not cloning anything. We just want the cord blood, and you can take your baby home. We don't want any of your babies. But the cord blood is rich in blood-forming cells. Patients have options to where, like I told you guys, you can publicly donate it, you can private bank it, or it can go in the trash. We do let them know that it's completely safe for them. We never alter the care of the mom or the baby. And unfortunately, it's not available everywhere. So that's a big one of the cons that we deal with is patients, we want word of mouth is always good, and we want them to tell their friends and their family about our program. However, we're not at all of the hospitals in the Atlanta area or even in the country. So that's the only thing that we hate, that we have to tell them if one of their family members are in the room and they're like, oh, I'm delivering at another hospital. If it's not one of our hospitals, then at this moment, they wouldn't be able to donate with us. We do let them know that it cannot be stored. You cannot pull your private kit over to our bank. And it's only just because, if I'm not mistaken, Marcie, it's different ways that we store it. Marcie?
Yes, and there's different requirements for a family or private bank versus a public bank.
So we do make sure that they know that, because sometimes they would have privately banked with their first child, and they're like, oh, well, this is perfect. Maybe I can call and get it switched over so that it can go in that public bank and on that registry, but we're not able to do that. So we always say, like, well, if that's good, you can have your private one there, and now you have a public one on the public registry that can help save someone else's life. So we try to ensure that they understand that, and we do let them know that the donor and the recipient will never meet. So all the identifiable information is never released to the recipient, and that's what we try to help them understand, because, you know, people are very concerned because this is their child, they're bringing their baby into this world, and they don't want someone else to have all their baby's information. But we let them know that it's not like bone marrow, where they are able to meet each other. With the cord blood, they never meet each other. And then, like I said earlier, the OB or the midwife, they never alter the care of mom or baby. It's done in utero. So it's after baby's already been delivered. The baby's cord is clamped and cut. Baby's either on mom's chest or at the warmer, and the provider will get the collection before the placenta is delivered. And it's collected by way of, it's a large gauge needle, and it just drains into gravity into our collection kit. So usually we get a good minute or two where you can get all that cord blood that's left over, but always they put mom and baby first. This is a good view of our bags and what our collection kits look like. The main go-home message we have with our providers is to get as much as possible. It's a correlation with the volume and the number of stem cells, but it's not necessarily always true. So the more the volume, hopefully the more stem cells that's in our collection. So our coordinators do go to the deliveries to assist with the OB or the midwife doing the collection, because we want to make sure that if it's still draining into our bags, that they keep that needle in that cord so we can continue to get the blood. So we try to make sure we go to all of our deliveries. And these are just great examples of collections and what we're looking for. So the first collection kit shows that it's below that white sticker that's at the top, and it's probably about halfway through. Typically, when it's shipped to our lab and they weigh it and they spin the cells down, we usually don't have enough cells in it. Collection that looks this way. But if you go to the next one, it shows that this is a pretty good collection. It meets that top white sticker. So that shows that that's, it's a possibility. We usually kind of think that we'll be able to get enough stem cells out of that. And then our goal is the optimal volume one, where they get as much as they possibly can. And it's really dark and it looks like it's full, it's heavy. And sometimes we think like, okay, hopefully this will have enough stem cells in it. And that's what we would like for them to use.
We also talk about the color of it, that the lighter color looks like a rosé, and we want it to look more like a dark Merlot all the way to the left. So there is something to be said for the color of it also, just from an anecdotal perspective as we look at them before we actually test them.
And then this is just what we see in our collections and the units that are actually shipped out and translated into patients. So the 19%, those collections were anywhere between 100 mLs and 135 mLs. So it's only 19% because it is a weight-based drug that they administer to the patient. So typically, that's how you correlate the two. 48% of our units that are transplanted fall in between that 135 mLs and 170 mLs. And then we also have about 33% fall between the 170 and 240 mLs. The goal, though, is for us to try to get as much as we can and go to the 170 to 240 mLs, just because they like those units that have more, since it's a weight-based drug that they're administering to their patients. So that's why it's important for us on the collection side to ensure that these doctors or or midwives are getting as much cord blood as possible. And I will let Marcie take over.
Yeah, so I'm going to just talk a little bit about our own public cord blood bank, just to give you some perspective of what it's like in a public cord blood bank. And there are 8 public cord blood banks in the United States that have their FDA license, and we are one of them at the Cleveland Cord Blood Center. We received our FDA license in 2016. We were established in 2008. And then we have our processing facility is in Cleveland, and we've collected over 60,000 cord blood units, and over 570 of them have been used for patients in transplants. We also opened a research and development laboratory in 2015, and the staff there is working on research of new uses for cord blood besides for blood cancer. So they're looking at things like Parkinson's disease, using the cells from cord blood for wound healing as a topical treatment, also using the cells from cord blood for treatment of autoimmune disorders like diabetes. So we're really proud of that new laboratory. So I thought it might be good to take a minute to, this slide shows the different things that a cord blood that's donated to the Cleveland Cord Blood Center can be used for. So the cord blood gets collected and then it's shipped to our lab in Cleveland. And then they do some initial tests and review the consent form also to see if the donor agreed to let it be used for research. So if it meets the clinical criteria, it goes to the top line and it's frozen and stored. And then it gets added to the public registry where a transplant physician, if they're looking for a stem cell transplant for their patient, they can search just the de-identified barcode number, not anything about the donor. And if a transplant physician picks the cord blood that matches one of their patients, we do run a couple of confirmatory tests to make sure that we saw a little segment of the cord blood, and we retest it to make sure that we didn't do anything during the freezing process that may have made the cells not function the way we want them to. And then we ship them frozen to the transplant centers, and then they're infused in transplant. If the cord blood doesn't meet the quality testing that it needs to be in that clinical top pathway, then if the family that donated the cord blood said it's okay, then we will also use them for research. In that instance, they're de-identified completely. They don't have any patient information on them. And we may use them in our own research lab, or we have investigators around the country really that we can ship the cord bloods to so they can use them in their research. So it takes a huge team of people. We have 35 employees of the Cleveland Cord Blood Center, and then probably another 15 or 20 that are work in the cord blood program but may not be our direct employees. Like, for instance, at Emory Midtown and Piedmont, the cord blood coordinators are employees of the hospital, but we have a service agreement with the hospital, so we pay some of their salaries, so we kind of feel like they belong on our team too. They are the ones that do a lot of the work. I did want to take a second to just talk about how we were founded. Our founder and medical director, Mary Laughlin, is a transplant physician that trained in doing stem cell transplants in her fellowship after medical school. And she felt that patients that received umbilical cord blood had a better quality of life after the transplant. And she has really made it, at the time when she was a fellow, cord blood was mostly used for children. And she made it her life's work to prove in her New England Journal paper that cord blood was a good treatment also for adults. So she did that kind of clinical research and then established the Cleveland Cord Blood Center in 2008 because there wasn't a public umbilical cord blood bank in the Midwest at all. So she's the reason why we're here. And she's also did the first transplant in an adult leukemia patient in the United States. So now Candice is going to take the time to talk a little bit about Atlanta's public banking programs and the impact that they've had.
So with the Cleveland Cord Blood Center, we have 5 sites in 3 different states. So we have in Cleveland, Ohio, we have Fairview Hospital and Hillcrest Hospital, which are both Cleveland Clinic hospitals. I personally came from Hillcrest Hospital. And then we have 2 hospitals here in Atlanta, Georgia. We have Piedmont, Atlanta, and Emory Midtown Hospital. And then more recently, we've added Kaiser to the team in San Francisco. So we're trying to make sure that we're strategically placed in certain areas to try to increase our collections from minority patients or those diverse patients. So we're seeing a lot of good things that are happening because of our placement of our locations. Next slide. So this just is to show you guys like the different things that we're using our cord bloods for and where they're being shipped to, and just to give you an idea of what we're bringing to the table with the Cleveland Cord Blood Center collecting at all these different hospitals. So in 2017, we've noticed that our recipients ranged in ages from 1 to 74. So like I said, a lot of patients think that it's just for babies or children, and we try to help them understand that it can go to anyone. It's not necessarily that it's a certain age group that the cord blood can be the cord blood transplant can be transplanted. The race of our recipients that are getting our cord bloods are 84% of them have been Caucasian, 9% have been African Americans, and 7% have been Asian. And our units have been distributed. 85% of our units have stayed within the U.S., and we've shipped out internationally 15% of our units. And they have been collected to treat different diseases such as ALL, which is acute lymphoblastic leukemia, AML, non-Hodgkin's lymphoma, severe plastic anemia. And I've actually personally met someone who's received one, and it was just a patient's family member. And she's actually received a cord blood transplant. So I thought it was really cool to see this is the work that we do, and you never know who you're going to reach and where in this person's family when they choose to donate, even if they've had a situation where they've had a family member who's received a cord blood unit. So, Marcie, I don't know if you want to explain kind of the map for me.
So what we did was try to obviously the icons in blue are where our collection sites are, and then the darker red where you see Texas, Minnesota, and New York, those are where the majority of our cord bloods go to for transplanted patients. So all 3 of those states have big cancer centers that utilize a lot of cord blood. And then as you can see, we hit the majority of the states. We've at least sent 1 or 2, and then the blue ones are the states where we haven't sent any yet. So we're very proud of the fact that we've gotten coverage through the vast majority of the United States with cord bloods donated to our center. So we're really proud of that fact.
Thank you. And then this is just to give you a kind of a view of what each hospital has done. This is for from 2008 to 2017, since we're not done with 2018 yet. Hillcrest has collected over 2,000 units. Fairview's collected over 1,700. Piedmont Atlanta has collected over 1,900. And Emory Midtown has collected over 1,300. And Kaiser, as of 2017, collected 791. If I'm not mistaken, that was their first year, correct, Marcie?
Yes, that's correct.
Okay. I wasn't sure of our actual start date. But so we're doing good as far as the collections. I mean, the patients really take to it if they're not choosing to privately do it, or they don't meet and they meet our criteria, because we do have things that we have to check off to ensure that they don't have a history of. But we're doing really good. Patients are very happy to see this program, and especially when you explain it to them, they really get excited and get involved in it. So we have about 9,600 units, probably plus, in our bank right now that are waiting to be transplanted. 525 have been distributed up until 2017, with 17 countries being reached. We have sent out about 8,400 units for research, and through all 5 of our sites, we probably receive about 26 units a day. We ship pretty much every day. I think all of our sites do not ship on Saturdays. And as of 2018, Piedmont has shipped units for transplantation. We've had 18 units. And then Emory, we've sent out 16. So that's just for 2018 for those 2 hospitals. So we're making really, huge strides in this, and we're just happy to be able to have this as an alternate option for patients who may have never found a match. We did begin at Emory Midtown in 2013. I helped with the start of us opening and training everybody. And that's just some of us in the picture. I'm in the middle. Marcie's next to me with a white sweater. And some of these women in the picture are coordinators and management. And then behind me is Nathan, and he was one of our recipients of a cord blood transplant. But Marcie will tell you more about that before we end. So we have trained over 80 OBs and midwives while at Emory Midtown, and really educating them on the importance of cord blood and collecting the cord blood. And they've been really great with us. We've collected over 70% of our collections have came from minority donors at Emory Midtown. So it's a vital hospital for us to be at, because we're really getting some good units to be able to store and have an option as an alternative for a patient who cannot find a match. And then this is just some statistics from Emory Midtown, and the blue line represents how many units were processed from 2013 when we started to 2017, and the red line across the top just shows how many of the live births that we've collected. So we've done really well. They work really hard, and it's a busy hospital. So we're doing really good with collecting these units and ensuring that the patients are educated. And then this is a slide that represents 2 of our coordinators from Piedmont and one of our OBGYNs who assisted with the startup of our program at Piedmont, Atlanta. We began collecting in November of 2012, and all of their OBs and midwives have embraced us and been very happy to have our staff there to collect cord blood for them. We've trained over 40 midwives and OBs while there, and collected over 6,000 units since we've opened, and 53 have been transplanted directly from that hospital. And then this is another chart that shows you how many units we've collected, is in the blue, from 2013 to 2017. The red represents how many of those units were processed. Like we said, none of them are always eligible for processing, so we do ship them out for research. But also the green line just shows you how many of those units each year we've distributed to different patients. And I'll let Marcie finish up from here.
Yeah, so I hope today that Candice and I have given you some background information about public cord blood banking and the options that families have when they're having a baby with their cord blood. So, they can donate it to a public cord blood bank like ourselves. They can pay to have it banked in a family bank. They can utilize some of the resources that Candice outlined about sibling donation if there's a direct need for it. But unfortunately, still in the United States and probably across the world, most of them do get thrown in the trash. But I want to end with a lot of these faces in this last slide that just show we're eternally grateful to be part of this process, and the four pictures in the center show four different people who have had cord blood transplants that probably had limited or no other options for transplant because either of the dimensions of their disease or their HLA typing. They did not have, they either did not have matches in the adult registry, or they had a adult bone marrow transplant and it wasn't successful. So for Candice and myself and the folks that work in this space, we think of the fact that there's 500 of those faces walking around because a family chose to donate their umbilical cord blood to a public bank. And it takes a lot of different moving parts in order to make that happen. I talked a little bit about our founder and medical director, who is in the top left corner, but we also receive extensive funding from two families. The picture in the top left corner or right corner, their family, they had a daughter who had a blood disorder. Then she unfortunately passed away in her early 30s. So that family feels like, if they can help, if she was born today, she would probably have some more progressive treatments and maybe even an umbilical cord blood transplant. But they have helped to fund us so that their intention is that if they can save one family from going through what they did, then the investment in public banking is worth it. The same with the family in the bottom left-hand corner. The patriarch of their family had leukemia also and was treated with drugs and not necessarily a transplant, but they saw an impact that could be had with public umbilical cord blood banking, so they invest in us also. And we wouldn't be able to do any of this without the families that donate their cord blood. It's an altruistic donation. It's just like when you donate blood. The intent is that it's going to be used for someone else, and then if God forbid you or your family need it, then someone else will donate a cord blood that'll be relevant for you. And we also rely heavily on medical providers, nurses and physicians and technicians and assistants. We do not pay any of our providers any funding for collecting umbilical cord blood. They donate their time. They don't bill us. The hospitals, we do pay some staffing costs and minimal facility fees, but they have donated their expertise and to help us to get these programs off the ground, especially in Atlanta. So, we really are proud of all the different altruistic acts that make this whole thing happen. And medical providers like yourselves are really a big part of it. And to make sure that families, there's a million questions that they have when they're going to have a baby. And we understand it's one piece of it. But, if we can have families at least have thought about what they're going to do with their cord blood and make a decision before they go to have their baby, then that's our educational goal. So I think we do have a few minutes for questions.
Thank you. That was great information. I'm going to open up the question board right now. So if anyone has any questions you want to either type in or you can raise your hand. There's a button to kind of raise your hand, and I can try to unmute you from there. Well, I have a question while we're waiting for folks to put them in. I noticed on the Emory Midtown slide, there was a significant spike in 2015. Are there certain things that lead to increases that you see in terms of donations?
Well, there's lots of things, right? Some of it in 2015, I think they may have had a higher birth rate too. So our ability to collect and consent patients depends a lot upon how many patients are there. So I
Okay.
think 2015 was, in my opinion, was a perfect storm of they had more patients that year, and also all of the staff got trained and was ready to go. You know, the learning period was over, and then we
Okay.
have it kind of tail off a little bit.
Thank you. I'm checking the question board. Let's see. Any other question? Any questions for our panel or for our presenters? Tia Rose just wanted to say good afternoon. Okay. Okay, I'll be able to unmute you. We have one here. Ms. Sanders?
Hello.
Yeah, you're unmuted. You had a question for our presenters?
I do. I'm actually typing it.
Okay. Okay, well, while she's typing, we have another one. Narissa, you are unmuted. Narissa Hill? Oh, she said she's typing too. Okay, no one wants to talk. They want to type.
That's
Okay. Okay. If the mother is doing delayed cord clamping, how will this affect the donation process?
That's a really good question. I was wondering if that was going to come. So it does affect it, right? There is data in the literature that shows that if the delayed clamping is 60 seconds or less, then the likelihood of a cord blood being able to be used for clinical transplantation stays about the same. You know, the likelihood doesn't change very much. It's irrelevant. But the data does show that if you go between 60 seconds between 60 seconds and 2 minutes, it reduces the likelihood that they would be able to be used in transplant by a pretty large percentage. And then if you go over 2 minutes, then it's very unlikely that it would be able to be used for transplant. So when we're counseling potential donors about it that want to balance between delayed clamping and donating their umbilical cord blood, we just tell them it's kind of like a balance, right? If you delay clamp 60 seconds or less, then the unit that you donate to us still has a pretty good likelihood of being used for clinical transplantation. If you are deciding to do more than 60 seconds, it's probably less likely to be used for clinical transplantation. We could still use it for research, but we just want to be transparent to them about what the likelihood of it being used for is with delayed clamping.
Thank you. Our next question was just wanted to clarify that only the 5 hospitals you listed are only patients from those hospitals can donate or store their cord blood. Is that correct? That was a question
with us.
from the audience.
That is, but there are a few cord blood banks in the country that will do mail-in donations. We have not gotten that program running at our center yet. So if you come across a patient that's interested in donating to a public bank and they're not delivering in a hospital affiliated with a public bank, the best resource is to go to bethematch.org, and they list by state all of the public banking hospitals and also a few places that will take mail-in donations from families delivering at hospitals all over the country. I know that Grady Hospital in Atlanta has a mail-in program, and I believe those units go to Duke University, to a public bank, just like ours, but it's housed at Duke. But there are some mail-in programs around, but bethematch.org is the best place to go for information. Or Parents Guide to Cord Blood is another website that's got a lot of great information for families to read about before they have a baby.
She says, thank you. Anyone else have a question for our panel? We have a few more minutes. And certainly, if this webinar will be available afterwards, if you want to share with your colleagues or just to watch again if there was anything that you missed. So I will get that posted. And if questions come up afterwards, please feel free to shoot me an email, and I will certainly get it to Marcie and Candice. I think that may be it. I don't see any other questions right now. So thank you, ladies, so much. This was very insightful, and I hope to have you all at the conference next year.
We hope so, too. Thank you for having us.
Yes, thank you.
Yeah, absolutely. And again, to anyone in the audience, if things come up, please feel free to email me, and I'll get it right to them. And you'll also receive an evaluation probably by tomorrow. As soon as you complete that evaluation, you'll have your certificate for 1 contact hour via the Georgia Nursing Board within a week. Okay, so thank you all very much. And again, you can check our website for additional webinars. I think we have one more before the end of the year. So yeah, check us out, and thank you again.
Thank you.
Thank you. Have a great rest of your day.
You too. Bye-bye.
Bye-bye.
Bye.